Good afternoon, everybody. My name is Michael Hauder. I welcome you very much for this afternoon symposium entitled Artificial Intelligence-Powered Quantification of Coronary Physiology and Vulnerable Plaque, Opportunities for Novel Treatment Option, a symposium that is sponsored by Pulse Medical. So I want to give a brief introduction. We all have to appreciate that during the last years we have significant improvements in coronary angiography-based detection of physiology in our coronary artery tree. And this is now enhanced by novel artificial intelligence-powered methods that create parameters which are much more versatile and on top of that also allow us to get information about the physiology within the vessel wall with respect to the local wall strain. And this just from a single plain coronary angiography. On top of we have these well-known intercoronary imaging technologies, but nowadays optical coherence tomography is also enhanced by getting information about the physiological composition of the plaque and the arterial wall in the direction of fibrous tissue, lipids, calcifications, macrophages, and crystals. On the other side, we got new, not really new, but renewed devices, technologies, bioresorbable scaffolds, a revival with this last generation of bioresorbable magnesium scaffold that allows us now to move into directions which are beyond just treating a coronary lesion. And a combination of that will be part of the objectives that we like to cover with this session. First, to share new data on the Murray law-based quantitative flow ratio, the muFR, pre, during, and post-PCI from a single angiographic view, to illustrate how the vulnerable plaque and hemodynamic stenosis significance can be identified from artificial intelligence-based analysis of radial wall strain from coronary angiogram, and to review the effect of a resorbable magnesium scaffold implantation on vulnerable plaque composition and evolution. So this is your facilitating team. I'm happy that William Wines is taking over the spokesperson's role. So he's taking care of your questions. You can post your question via the app, but you can also easily use the stand-up microphones and post your question during the discussion periods. We have two distinguished discussants, Joost Dammen and Graziella Pompei. And then we do have 5 speakers in alphabetic order: Stefano Galli, Michael Yona, Chen Guang Li, Cheng Xiang Tu, and Jung Yang Yang. I hope I pronounced adequately. So this is the flow of the session. It will have 2 parts. First part will be on the angio-based physiology parameters with artificial enhancement. And the second part will be on the bioresorbable scaffold, the magnesium scaffold, the nowadays called FreeSolve because it is CE marked at the moment. And we will have a junction because you see identification of a vulnerable plaque with these new technologies and treatment options on the other side really opens new doors. Having said that, William, I would like to ask you to introduce our first speaker. Thank you very much.
Excellent, Michael. The stage is set beautifully. There is some seats left in the front, so don't stand behind. And I'd like to invite Prof. Sanven Zhengxiang Tu, who will open the first part, the first section of the symposium, and it's about the methodology and validation of angiography-based computation of all sorts of very relevant information regarding coronary circulation and myocardial perfusion.
Thank you, Professor Mai. It's my pleasure to be here. This is my disclosure. We know that FFR and OCT are available in the cath lab to assess coronary physiology and plaque vulnerability, but because it's an actual invasive procedure, so the adoption is limited in some countries. So we propose the novel AI-based methods to compute FFR and the microcirculation resistance, and lesion vulnerability from a single angiographic view. And this was awarded Best Innovation 2 years ago at EuroPCR. So as you can see, after the computation, you have this color-coded map here, a radial wall strain co-registered with the angiogram, indicate that the vulnerability of the lesion, and also you have the pressure drop, calculate pressure drop along the vessel. So let me give you a little bit introduction of this new technology. muFR is the second generation of QFR. So first generation, only single vessel we are reconstructed. And because side branch was not detected, so the reference diameter is linear tapering, so that could be less accurate in bifurcation lesion. In the second generation, we call it muQFR or muFR. We will detect all the side branch, and using the size of the side branch to create this step-down reference diameter, which is more like the healthy reference. If the vessel does not have stenosis, then you calculate the muFR, and also you can calculate from a single angiographic view. So the question is that how does that compare to the two-view QFR? So we published a study last year. As you can see that the mu QFR, we calculated from one of the projection, and also we used the most certificate model, the 3D reconstruction, the main vessel, and also the side branch to calculate the mu QFR in 3D. And these are the results. As you can see that the single view QFR is almost as good as the two-view QFR. And why is this? So maybe I can explain with the figure. So first of all, indeed, there's many cases you have eccentric lesion, but the lumen can be symmetric. So if you take one projection, you get this. If you take a second projection, you will get the same lumen because symmetric lumen. So if you do a perfect correlation between these two views and create a 3D, then the lumen will be also circular shape. But if you make some imperfect correlation, so the first view does not correspond very well with the second view, then you will have a false lumen. So this actually introduces actual error in the 3D reconstruction that could compromise the use of the second view in the computation of QFR. So we further tested this methodology in a bigger study. So we did a blind analysis with Professor Koo using the flavor study population. As you can see, it's about 800 patients. The feasibility, even in retrospective study, it could reach the 95%. And there's 90% diagnostic concordance between the muQFR with the wear-based FFR. So in collaboration with Professor Bozota, we further validate this one in the FORZA study population. So the post-PCI muFR predicted the 3 years target vessel failure. As you can see, post-PCI, then if muQFR is below 0.89, there's higher event rate compared to if you have a normal flow. Then I come to the radial strength from angiogram. So this is the concept. If you have a vulnerable plaque behind this, then because there's a difference in pressure, systolic pressure and diastolic pressure. So the pressure difference interacts with the vessel composition that will create difference in lumen deformation. So if you have a vulnerable plaque, you have more deformation in lumen. And actually this information is hidden in the dynamic angiogram. So if your software is smart enough to detect this very subtle change and quantify it over the cardiac cycle, then we have the radial wall strength. And this has been implemented in the AngioPlus core software. So after single view muQFR, if the image quality is good, then you click and you get this color-coded map immediately. And then you have the red color indicate that it's hotspot behind this, and that's suggesting there's a vulnerable lesion behind this. So we did a number of validation study. The first one is looking at the correlation between the angio-based radial wall strength with the OCT-defined vulnerable plaque. So defined by the combination of the large lipid core and the zinc cap in a parameter called lipid-to-cap ratio. As you can see, that they correlate very well. The second study is looking at the prediction of lesion progression. It turned out that this radial wall strength is the most strong predictor for intermediate lesion progression. And the third study was published last year. We're looking into the patient who developed acute myocardial infarction. So we went back to the previous angiogram before developing the acute myocardial infarction. As you can see that the presence of the high radial wall strength in this AMR group is significantly higher than the control group without developing the acute myocardial infarction. And we further analyzed the favor 3 China study population. We analyzed all the non-flow limiting vessels. As you can see, in non-flow limiting vessel, if you have a higher radial wall strength, event rate is significantly higher. If you have a low radial wall strength, so flow normal and radial wall strength is also low, then you have lower event rate. And this result has been confirmed by in the European population. So this study was presented by my colleague Dr. Huang yesterday in the hotline section, the target age study. As you can see that there was a good correlation. The artifact and muQFR both predict the 5 years clinical outcome in the target age study population. And if we use only the good image, the angiogram with good image quality, as you can see, it increased the predictability. The hazard ratio increased for both, and it seems that radial Watson has even stronger predictor compared to the muFR. So, ladies and gentlemen, in conclusion, assessment of coronary physiology and lesion vulnerability can be performed solely from a single angiographic projection. And muFR correlates well with FFR has potential to facilitate the adoption of physiology for prognostic prediction and procedure guidance. High radial Watson identify vulnerable plaque defined by OCT and is independent associated with intermediate lesion progression and non-procedure related myocardial infarction, where low radial Watson is associated with good clinical outcome. And both muFR less than 0.80, 90, and radial Watson larger than 13 are associated with higher non-cardiovascular related target mass in 5 years. And the integration of muFR and RWS assessment has potential to provide a cost-effective strategy for clinical decision-making in a cath lab. And thank you very much again for your attention.
Thanks a lot, Professor Tu. We will bring you back on stage after brief presentation of two clinical cases that will illustrate how these concepts can help in the clinic. And the first one will be presented by Simone Fezzi. Dr. Fezzi was with us in Galway for 2 years, and he's now back in Verona. Thank you, Simone.
Thank you, William, for the introduction. So I'm going to jump directly to the case. We are talking about a very young patient, 40-year-old male with arterial hypertension, dyslipidemia, that came to our attention back in 2015 due to an acute coronary syndrome, a lateral non-STEMI with lateral ACG changes, and rise troponin, normal LV function at the echo. This is the angiogram at baseline. We can appreciate a suboccluded marginal branch that was treated with PCI, and absorb implantation with a 3.5/28 absorb accurately post-dilated was performed. The left anterior descending didn't show any significant disease, while the right coronary artery was dominant and presented these intermediate stenosis in the proximal part. So, as per guidelines, we performed a physiological evaluation of this non-culprit vessel, and we detected non-ischemic values of both FFR and IFR. So we deferred the treatment on the lesion. Patient was discharged and enrolled in a secondary prevention clinic with optimization of cholesterol control and blood pressure control. But after nine months, he came back due to chest pain, rise troponin, inferior leads changes, and this is the coronary artery now. So we have an inferior, a right coronary artery showing a progression of the disease with some apposition of thrombus in the plaque. So also this lesion was treated successfully with an absorb implantation. And I want just to show you the 9-month result of the marginal branch revascularization with the bioresorbable scaffold. So post-hoc, in retrospect, we performed an integrated computation of physiology and vulnerability with the AngioPlus software. And as you can see, physiology is consistent, angio-derived physiology is consistent with the pressure wire. So we have a negative muQFR value, while radial wall strain shows a very large hotspot detecting a vulnerable plaque in that lesion. So, in conclusion, in some patient subsets, deferral or stenting based on coronary physiology is associated with an excess of cardiovascular events, especially in diabetic and acute coronary syndromes. Radial wall strain derives plaque vulnerability from a single angiographic view, so radial wall strain hotspot detection might potentially improve patients' risk stratification and empower secondary prevention strategies. Thank you for your attention.
I take the second presenter to be introduced here, Dr. Yuan-Qing Yang, who will going to present a case example of a vulnerable plaque identified both by the regional wall strain and OCT.
Thank you, Chairman, and good afternoon, everybody, my colleagues. Okay, I'm here. During the next few minutes, I'm here to show you an easy example what I did in the daily practice with which I use RWS and LCR, which is derived from the OCT. Okay, I have nothing to declare. There's an old gentleman with the diabetes and OMI who suffered heart dysfunction and present with worsen symptom for a few months. We found the right coronary distal segment is totally occluded with some struggling. We open up it and drag a broom in it. And but the point is the LAD. You can see there is some stenosis at the proximal and mid LAD, especially here the focal things. Yeah, of course, we regularly use the QFR. Okay, that's the next generation. We call it muFR. Good thing is the value is negative, 0.86. And on the top of muFR, we can calculate the RWS just show the maximum. We can see the legend here, everything, nothing is in red, and maximum value of RWS is less than 13%. So it's happy. Also, we checked the OCT for this case, and we didn't see any defect or other vulnerable plaque. And also with the OCT data, we calculate the lipid to cap ratio, which we call LCR, calculated by the lipid burden in the percentage divided by the cap thickness in micron, and which the cutoff is 0.33. And for this case, the maximum LCR is just 0.13. So everything is so happy. We found nothing dynamic significant, and nothing is vulnerable. So it's easy for us to make the decision to defer this patient. And this is the example to show the RWS and LCR, which indicate the vulnerability on the top of the muFR or OFR index, which indicate the dynamics significance in my daily practice. Thank you.
So thank you very much. It would be a pleasure of the two if you can join for the discussion. Are there questions for the first part on muFR, on regional wall strain? Yes, please. If you can use the microphone, please. In the meantime, maybe I can start. It's very appealing that you can get this information just from a single view, a monoplane coronary angiography. Can you use any projection for that, or any kind of requirements in order to perform the coronary angiography?
Good, thanks for the question. So if you, the projection is exposed to the lesion very well, without overlap and seeking for shortening, that could be used for the muFR computation. And for radial wall strain, we do recommend some projection to be used. I think that's more important to use the recommend view compared to the any view.
Thank you, please.
How does this quantification get affected by things like having a muscle bridge, in a coronary artery, or some sort of a congenital abnormality, abnormal origin, etc.? How does it? Do you get the same valid, result, in this kind of situation, or all the calculations are different based on different anatomy and different courses of coronary artery flow?
A good comment. I think that for the if you have micron bridge, then the radial wall strain is also very high. So this is something that we remember, that because it also compresses the lumen during cardiac cycle. But for the muFR computation, so normally we're using one of the frame. But in this new generation, we integrate all the frame during cardiac cycle. So actually, you can use the dynamic of the lumen in the computation of bearing cap. So it's an advantage compared to the previous version.
Okay. Any other question? Can you always please join the microphone? Otherwise, I don't think we can hear you well enough.
Thanks for the great method. I'm just wondering if there is dissociation between radial wall strain and the data from OCT, do you recommend to have intervention, or you recommend what may weights more?
Very difficult question. I think now we can identify vulnerable plaque as the OCT, but what to do next, whether we treat it or not, I think this is something that we need to test in future study. So actually, one of the study called Favor 5 AMI study has been initiated to looking into the combination of the angio-based QFI and also the radial wall strain to make decision.
If you do allow me, just to keep that in our minds, what is the cutoff value for the micro QFR and also for the regional wall strain between normal and pathological? You see, we have in our mind for the FFR 0.8 and for the resting IFR parameters 0.9. What is with your parameters? Just to get that into our brains.
So the muFR or QFR is exactly matched to a wear-based FFR, so also 0.80. And for the radial strain now, in the Favor 5 AMI study, also in the target AC, we are using the 13% as cutoff value.
Okay. Now, what I find extremely appealing is the fact that you can take your coronary angiogram, which totally looks normal, we have plenty of them, and now send that to the system, and the system tells you why the regional wall strain, that there might be some hotspots. So the question is now, can we do that? Can we use our recorded coronary angiographies to put into your system? Or do you have certain pre-requirements to the angiography, frame count, for example, etc., that you need in order to make your calculation?
So very good comment. As long as you have good image quality, we can analyze them, but we recommend that the frame rate need to be at least 15. That would be better, yeah, indeed.
Okay. So
we have a question from the audience, and it's about coronary sinus reducer. I mean, it may not be directly related, but the question is whether that could be useful for treatment of angina for epicardial disease not amenable to PCI, like too diffuse or too complex. So if you agree, Prof. Tu, I will ask maybe Joost, you want to address what is the role of coronary sinus reducer in there?
Thank you, William, for this a little bit off-topic question. I think what I would say is I think this index adds to our armamentarium of indices that can be used to assess block vulnerability. With one key difference is that it can be readily available. I mean, I think there are little people in the room who would measure cap thickness on the spot in the cath lab online. Nobody will do that. The same counts for measuring lipid burden. NIRS is rarely used. But now with this angio-based index, you can get a very quick and swift additional index that appears to predict vulnerability. So that can be used for preventing or to predicting future events.
Yeah.
Predicting future events, I think, is a different animal than treating angina. I think treating angina and also, let's say, presence of angina and the correlation with this index has not been defined. So I would like to keep the issues separately and take them as separate entities in this case.
Yeah, I guess what the colleague was perhaps alluding to is that there have been some attempts to compute also microvascular resistance from the angiogram, isn't it, Prof. Tu? You did, some other colleagues have tried, and maybe that will help as well to identify the right candidates for the coronary sinus reducer. So shall we close this book and come back to computation physiology? Yes, Simone. And in the meanwhile, Graziella, how do you see the role of radial wall strain?
Thank you, Professor Wines. I have some consideration, a question for Professor Tu, because you showed, first of all, congratulations for your presentation. So radial wall strain is able to predict plaque progression and subsequent future adverse events. So this supports previous evidence from studies such as the combine of FFR or CT, showing us a plaque with negative functional assessment, but high-risk characteristics have a significantly higher, 5-fold higher risk of MACE. So I would like to ask you, since this could pave the way to future studies, are there any contraindication in performing the radial wall strain, for example, how severe calcification impact on this index?
Very good question. I think that first of all, like the myocardial embolism, So myocardial bridge will affect the radial wall strain. So that's something we exclude for analysis if you have micro bridge. And second, as you mentioned, that the calcification, theoretically, it should not be a problem. But if you have very calcified lesion, then the lumen contour will becoming less clear in the angiogram. So maybe you need to improve your image quality in order to assess it. But theoretically, it should be okay.
Yeah, just a short question to Prof. Tu. So, as a perspective, do you think that this technology can also be applied for CT, so for non-invasive assessment?
Because I think we are trying it with the new photon counting CT. The problem is that you need to make a full acquisition with respect to the gating. Then it increase the contrast used. So clinically, if you do prospective gating, then you cannot use this one. But if you do retrospective gating, indeed you can do that. Like you need high resolution.
But basically, something maybe to clarify a little bit. So the muFR can be based on a single frame, correct? So you pick a optimal and diastolic frame, and the system will do the contouring and will give you a value. So with respect to the regional wall strain, you need a dynamic image, correct? So you need a couple of beats with 15 frames per second, not just a single frame. And that's indeed, I think, the answer to the CT question, which is typically not dynamic.
Single beat. You can do it on a single beat,
but a full cycle.
Several, full cycle with high frame rate. Ideal frame rate, you said, Sanvan?
I think normally we recommend more than 15. So if you have 15, it's okay.
So, I mean, plaque stress and strain have been seen as the holy grail of plaque vulnerability assessment along with imaging. We understand that radial wall strain is only in one direction, so it's an approximation by engineering, parameters. Are we losing much information, or how do you see, is radial wall strain enough? How do you see this?
Very good question. I think that the radial wall strain is in the right direction. But there's the other direction, for example, because of cardiac contraction. Actually, we have another one called bending angle. We published a study actually to assess the bending angle. The bending angle is reflecting more like the longitudinal direction, and that would influence the stenting result because it compressed the stent. So what we found in the study is that if you have a big chance of the bending angle during the cardiac cycle, so difference between systolic and diastolic, then there's higher chance of developing stenosis, especially at the circumflex altitude.
Thank you. Oh, very quickly then, short question. Speak very loud.
So the shear stress, you mean? Endothelial. Okay, there's different animal, I would say. The shear stress and the shear stress is because induced by flu. So the magnesium magnitude is much lower compared to the plaque stress. So plaque stress is really the mechanical stress. It's because cardiac contraction, blood pressure interact with the plaque composition. So endothelial shear stress is just flu, so the magnitude is very low. So I don't think that endothelial shear stress is a predictor for plaque rupture. It's good for plaque progression, slow plaque progression or initialization. But the plaque stress itself is really the trigger to this mechanical stress is the trigger for plaque rupture.
So thank you very much. I think we need to move now to the second part of this symposium, which is covering the topic of the latest version of the drug-eluting bioresorbable magnesium scaffold and its potential properties to address vulnerable plaques. So I would like to first ask Stefano Galli to tell us about the key features of this device, which is CE marked since a few weeks and has its commercial name FreeSolve, and tell us a little bit about the degradation characteristics.
So thank you, Michael, and thank you for the presentation. So this is my conflict of interest. Obviously, we have a device to try to passivate mechanical the plaque, especially the vulnerable plaque. We start from the Magmaris, the previous version. Now we move to FreeSolve, completely different device in terms of alloy, that change with junction of aluminum, and probably increase the time to scaffolding time to optimal vessel support more than 6 months. Change completely the thickness, especially in 2.5, 99, 3.2, 3.5 change, reduced to 117, and remains the same in the new size, 4.0. The reabsorption time remains the same. Another important point for the interventional is the completely different visibility of the marker, not two markers, proximal and distal, but unique oval tantalum marker that is more visible and obviously change portfolio. In terms of the performance, in terms of late lumen loss tested in the BioMag-1 trial, we observed that at 6 months reduction, 0.21 to 0.44 in the previous version versus new version of FreeSolve, less 52%, that maintain at 12 months. Another important issue is in terms of, in the BioMag study evaluation of the OCT, that important, no significant impact on late lumen loss scaffold after FreeSolve, and probably the better device performance irrespective of the underlying plaque characteristics, very important point. On the other hand, we observed that 99% completely reabsorbed struts at 12 months, and it is very important, the 43% reduction in the strut protrusion area between 6 and 12 months, and confirm the scaffolding time more than previous version. And this is a new line, and we test the new version of the FreeSolve with the drug-lutistan in a randomized control trial, and we have all answer in the clinical field. Thank you for your attention.
Thank you, Stefano. You can stay just there where you are, because you're going to show us now a case example of a vulnerable plaque that you have treated with this new device.
Okay. So this is 63 years old male with present in with anastomia, with anterolateral downsloping, culprit lesion circ, and significant lesion on proximal LAD. Intention was to fix culprit lesion and then stage the LAD. This is the other clinical characteristic. When the patient arrived to the stage, we have also performed a angio-based muFR offline, obviously, that indicate a significant stenosis on LAD, and obviously in the right part of the slide, the result of the circ. And then we test not only with the angio-based functional evaluation, but also with IVUS to identify the characteristic of this plaque. How happened in acute patient, we discovered two lesion, tender lesion. In the first, we appreciate 333 lipid burden index, and remember that more than 350 is high risk to event in outcome. And in the proximal, a lot of plaque burden now we see in the IVUS movement with the 388. So we decide to treat, to fix this lesion with a resorbable scaffold. We use a edge-to-edge FreeSolve implantation, 4.0 and 3.5. And in clear stand, you see very well the marker. And we have a little pinching of the diagonal branch. We treat with a mini kissing, but this is not the important point. The point is that when we repeat IVUS NIRS, we observe in the distal plaque a complete passivation, acute complete passivation with FreeSolve, but in the proximal part, an incomplete passivation, probably due to the large plaque volume, but remember that is in the acute phase. I hope to test this patient with IVUS NIRS and I hope with the radial wall strain after 12 months and to see what happened. So this is a final result, and it's possible to appreciate also the IVUS result, but it's very important because at the end of the procedure, it's very easy. We perform a angio-based muFR that confirm that if we fix 2 lesions, the perfect result after completely in 1 minute, it's easy to have a post-PCI. I believe that is an example of how works this technology, but obviously scaffold and vulnerable plaque passivation is a new concept, but need a combination of mechanical device probably, but obviously medical therapy. Thank you for your attention.
Thank you, Stefano. We're going to hear Michael Jona, and then we're going to have a discussion. So, Michael, you are going to talk about artificial intelligence-based plaque composition and evolution in patients treated with the Freesolve.
Yeah, so let's talk about intelligence in general. And I'm
Remember your time, please.
Yes, okay. I stick to the time allotted to this talk. So I'm talking on behalf of Hector Garcia, who will unfortunately not make it to this session, and we've performed the study together. This is my conflict of interest. We all remember, obviously, that bioresorbable stents were devised to prevent long-term stent-related adverse events, and we've talked extensively about issues such as late stent thrombosis, neoatherosclerosis, which is often seen in metallic stents. OCT has a unique resolution to permit coronary plaque content characterization, and eventually newer artificial intelligence-powered software, such as the OCT Plus software that we will see in a moment, enables automatic analysis of plaque components. So the objectives of this study were to compare the baseline coronary plaque composition before implantation of the Freesolve, which is, how is it called now, in relation to the late lumen loss that is detected by angiography. And this is from the BioMac-1 study. And to compare the serial coronary plaque changes between baseline and 12-month follow-up. So on the left part of this slide, you can see the study flow, which is most relevant, I believe. So you may remember that 116 patients with total of 117 lesions were enrolled in this study, and then you can see this flow. What it is important to stress is that you really have to carefully select those OCT pullbacks that have high enough quality to perform this analysis, meaning good flushing, etc. So at the end of the 12 months, you can see that a total of 96 pullbacks were of sufficient quality to perform this serial analysis. The baseline characteristics are listed here. I just want to point out to the most relevant ones, which is shown here. NSTEMI patients were included in the study. Those were slightly more than 20% of the patients. And as you can see, in terms of lesion characteristics, approximately 76% or 77 almost were class B2 and C lesions. Now, this is just a demonstration of what was done, basically. I'm showing you pre-implantation OCT, post 6 and 12 months follow-up. And you can see that this artificial intelligence-based algorithm is feasible within minutes to characterize the plaque components. And it's mostly doing that for fibrous tissue, lipidic tissue, calcific tissue, and then some minor components such as macrophages and crystals. Now, I'm trying to make this slide easily digestible for you. When you take the cumulative frequency curve of the late lumen loss, so the angiographic parameter, and you divide it in 3 tertiles, okay? So these are patients with lower late loss, intermediate, and higher late loss. You can see the associations with the underlying plaque components, and this artificial intelligent-based algorithm found an association between fibrous tissue, underlying fibrous tissue, and higher late loss, as you can see here. Now, when you do the same thing for an OCT-based measurement, which is, as you all know, minimum lumen area, which is most frequently used these days as a marker of efficacy, you can see that there is another clear significant association with underlying fibrous tissue. That means the higher the fibrous tissue to begin with, the lower the minimal lumen area you have available at follow-up after 12 months. And the most important point, I think, or relevant fact is shown in this slide. Because remember again, the strength of this study was the baseline OCT imaging post scaffold implantation and then 6 and 12 months available. So serial assessments could be done. And this is comparing pre-scaffold implantation and 12 months follow-up. And what was quite striking to us to see is then when you look at calcification, there was no difference, but look at the green columns and lines, fibrous tissue actually showed in the third column, you see the difference again, the delta, so it shows you an increase in fibrous tissue between baseline and follow-up imaging, which can be interpreted as such that there's healing occurring and a fibrous cap is forming above the scaffold. And then just below, when you look at the lipidic tissue, you can see the opposite. The delta is negative, meaning that there was a clear reduction between baseline and 12 months follow-up for lipidic tissue, and both turned out to be significant. So the proposed, and this is just a proposal, mechanism behind this, is that when you start with mostly fibrotic plaque, of course, this is a scaffold that has high radial strength, but it is not exactly the same as compared to stainless steel or cobalt chrome. You will see some level of recoil. And this will then eventually, in selected patients, turn into slightly larger late lumen loss. On the other hand, when you look at the lower part of the slide, when you have a mixed plaque with a lot of lipidic components, this is easy to penetrate and very soft. Then you will not see the same level of recoil and have also only modest or lower late loss. In both instances, and this is the key message, what we found is that there's a nice neocap, neointima forming above the scaffold without any signs of protruding struts or dismantled struts in the lumen. So the limitations here, of course, it's a single-arm study without comparator. OCT has limited penetration, which we know, so detection of the underlying plaque may be somewhat limited. The OCT Plus software has limited the analysis of deeper parts of the plaque. So consequently, newer OCT technology combining other technologies such as NIRS, as also already shown, is being introduced with improved lipid detection and thus should be preferred over OCT stand-alone catheters in the near future. In conclusion, the larger the fibrous tissue in the coronary plaque that was treated with DREAM-3G, Freesolve, the larger the lumen loss seen at 12 months. Following implantation of DREAM-3G, there was favorable healing of the vessel wall as shown by the decrease in the lipid area that was present in the OCT before implantation of the device in comparison with the OCT evaluations at 6 and 12 months. And this was accompanied by an increase in fibrous tissue. Both changes obviously indicate a positive impact of DREAM-3G on plaque stabilization. And with that, thank you very much, especially for the investigators.
Michael, thank you. Thank you very much for sharing these very interesting data. Graciela, you have a question for Michael?
Yes, again, congratulations to all the presenters. I have a question for Dr. Turner. Probably all of you can answer this question regarding, I remember last year when Professor Hauder presented the first in-human study regarding the DREAM-3G technology with the improvement in late lumen loss. And you presented the study you just published in the European Heart Journal Cardiovascular Imaging and how the scaffold implantation impact on the plaque composition. Congratulations. And but this means that the patient enrolled in your study underwent 12 months intracoronary imaging assessment. I'd like to ask you if you have experience in performing a CT scan for the follow-up of this patient after implantation of a DREAM-3 technology. Thank you.
Yeah, good point. And probably we all believe this is the future. because this is, of course, a well-regulated clinical trial where the regulatory bodies want to see intravascular imaging images to understand about the healing process. But I agree with you completely. In the future, we don't want to bring the patient back to the cath lab. So yes, we have experience with CT imaging with this scaffold, and especially with its predecessor, Magmaris scaffold. And it's absolutely possible. I mean, it depends oftentimes on other underlying conditions, such as the level of calcification, which in the CT can create artifacts, but it's feasible, and we are engaging into, hopefully soon, another study to clearly assess the feasibility of CT imaging also for follow-up in this scaffold. Yeah.
Michael, maybe you can recall the degradation process of the magnesium-based scaffold and how that might influence this kind of passivation of the vessel wall.
Yeah, that's also a very important point. So what we've been publishing is that after 12 months, essentially the scaffold is gone, and all you have left is some residuals of a relatively amorphous calcium phosphide, which is relatively soft. It's not to compare with vascular calcification. At 6 months, you already have 3/4 of the scaffold being resorbed, and yet in comparison to Magmaris, the radial force, outward force, is still much stronger. So it really does what it's supposed to do. It's scaffolding the vessel. So this is the difference from the previous generation. And this may, of course, impact on the healing process, because ultimately you want to have a scaffold resorbed relatively quick, so that it doesn't have the concern that we've seen with Absorb, where you have, after 2-3 years, you have dismantled struts hanging in the lumen. It needs to be embedded in the neointimal tissue, and this is what we targeted with this new scaffold.
Close the gap between part 1 and 2 of that symposium. Do you think we have enough data at the moment for the FreeSolve to let that move into a trial where we test what Stefano has shown us, really to pacify a hotspot that was identified by regional wall strain, and see on a randomized fashion how we can really protect a progression into an acute coronary syndrome? Do you think we have enough data for the FreeSolve at the moment?
Now, this is indeed a difficult one. I'm not sure whether I would engage into a randomized study with this topic. I don't know what to randomize against, if it should be drug-eluting stents or not. For sure, I think we should have the courage to engage into a prospective observational study to understand whether, if we do this, we see clear and safe healing of the coronary artery. So I would engage into a single-arm prospective observational study, similar to the designs that we know from Prospect, much smaller size, obviously. But this is what we need to learn. We need to understand how these arteries heal over time if we implant these devices, before we engage into randomized studies.
Yes, please.
Thank you so much for the presentation. Great trial. Concerning scaffolds, we're always afraid of going to the calcified vessels. Does your trial free our hands and we can try going to calcified lesions?
Yeah.
More afraid of fibrous than calcified?
Yeah, quite honestly, every time when we sit together, Michael Haude and William and the rest of the team, and we discuss these scaffolds, we get concerned when somebody shows us these calcified vessels, and we discuss, was this a smart idea to implant a scaffold? And for some reason, this analysis shows you that calcified lesion seems not to be of so much concern. The healing looks quite nice, even in a calcified. Now, we all understand what calcification can mean. I'm not talking about these cases where you think about rotablation or orbital atherectomy, where you just have that level of calcification that has to be treated with other ablative, therapies. I would not recommend to use a scaffold. But if you have some level of calcification, it may be feasible in the future. Imaging, in my point of view, will play a dominant role to differentiate calcification.
Thank you. And cutting balloons were used in your trial for the predilation?
You mean in the BIOMAG 1 study?
Yes.
It was allowed for predilatation. So as a matter of fact, it was important to achieve less than 20% diameter stenosis before you implant the scaffold.
Thank you.
Okay, William, in terms of time, we need to wrap up this very interesting session combining two hot topics in the field.
Thank you. Time was too short. We would love to spend more time discussing and reflecting on what we've learned here, but I'll try to summarize it. And before I do that, I'd like to thank Pulse and Biotronic for putting this symposium together. Then came radial wall strain that associates with plaque composition, and particularly the dangerous one, what we've seen on the NIRS, lipid accumulation. So it looks like areas where you don't have a significant stenosis by hemodynamic features, and if you have lipid accumulation, you will see high radial wall strain, and we've seen now more and more data showing that this associates with fast progression, unstable angina, etc., etc. So that is part one. And then comes part two, intriguing observations, beautifully summarized by Michael, although complex to understand, but showing that the healing and the interaction of the scaffold, this particular one, version 3 and 4, because resilience of Biotronic has been enormous in keeping research on this device. The interaction between bioresorption and wall composition is very interesting if we would apply this to vulnerable plaque, detected either by OCT or by NIR or by perhaps RWS. And that's why we designed this symposium before publication of the study by Dr. Park, the famous study showing for the first time in a randomized trial that if you take non-hemodynamically significant stenosis, you characterize them in terms of vulnerability by, in this case, intracoronary imaging, and you stent them with a drug-eluting stent, you're improving outcomes. Many attempts before, all failed. First positive study will be verified. And then comes the question, what do you do in terms of what you use to prevent these events? DES, okay, positive study. What about bioresorbable scaffold? What about perhaps DCB? So that's where we are. And I swear, we didn't know the results of the Park study when this was designed. And that's why I think it really opens totally new era for coronary intervention. I think there is a new wind for coronary intervention in chronic stable, because we are able from the angiogram to appreciate all the variables that determine coronary perfusion, plus massive unmet need, prevention of sudden death and acute myocardial infarction by applying focal therapy, I don't know which one yet, to those dangerous plaques that are vulnerable as identified either from the angiogram or in combination RWS and imaging. So exciting. I wish we could go on and discuss this for much longer, but for sure we will have many, many meetings in the future, and we need more data as well to validate these hypotheses. So thanks again to all the speakers. Thank you for the panel. Thank you for all of you.